Namaskar. Hello, my dear students. Today I am here with the part 2 of the topic Examination of Completely Edentulous Patient. In this topic, the physical examination I have already covered in the part 1 of the lecture. Today we will be discussing part of the intraoral examination and rest all we will be discussing in the part 3. So let's start with the intraoral examination. In this, we will discuss arch size and arch form, tori and its management, interarch space and its significance in fabricating the complete denture, maxillary and mandibular ridge form, vault form and the palatal throat form. Rest all points we will discuss in the part 3, that is the next lecture. Now, dear all students, these all mentioned points are very important. You will have to mention these points during your history taking and examination in your practical exam. Arch size. The arch size of maxillary and mandible dental arches determine the amount of denture bearing area available. The average denture bearing area for edentulous mandible is 14 cm square, whereas for the edentulous maxilla it is around 24 cm square. So larger the size, better will be the retention and stability. Engelmeyer classified this into three classes: class 1 large, class 2 medium and class 3 small. Class 1, the large arch size, is best for retention and stability. Class 2 is the medium. It has good retention and stability, but it is not ideal as it is for the class 1. Class 3, small. It is very difficult to achieve good retention and stability in these cases. Disharmony in jaw size. Any disharmony in jaw size not only cause compromised retention of either denture but also creates troublesome recording of jaw relations. Maxillary arch may be larger than the mandibular or reverse. This can be because of the first being the resorption pattern. Here the sequence of the tooth extraction also plays the role. Then comes disturbance in the growth and development or the genetic factors. As I told you before, the jaw relation has to be recorded carefully and occlusion has to be planned similar to the disharmony in the jaw size. Arch form. Arch form as classified by House can be class 1 square, class 2 tapering and class 3 ovoid. Class 1 square arch form is the best arch form to prevent the rotational movements. As we can see in the first picture, the tooth form is also selected accordingly the arch form, and central incisors are placed nearly on a line with the canines. The four incisors have little rotation, as we can see in the image. This gives broader effect to the teeth and harmonize with the square arch and also the face form in some cases. The clinical intraoral picture also shows the square arch form. Class 2 tapering arch form as shown in the first image. In this, the central incisors are a greater distance forward from the canines and assume a V shape as shown in the pictorial image. Rotating and lapping of the teeth is considered in this. This rotation of incisors distally reduces the amount of the tooth surface showing from the front. It actually harmonizes with the tapering arch intraorally and narrower tapering face extraorally if present. The center image shows the class 3 ovoid arch. This shows least or no resistance to rotational movements. The clinical picture shows the ovoid arch form. In chairside viva, you have to note down the arch form and its significance is asked by the examiner. In MCQs, it is asked which arch form gives the best resistance to rotational movements of the denture. Yes, the square arch form. And which arch form shows the least resistance? Yes, ovoid arch form, definitely. Tori, a very important topic for Viva and MCQs both. Torus is a bony enlargement present in the maxillary or the mandibular arch. In maxillary arch, most commonly it is present in the mid-palatine area, and in the mandibular arch, most commonly it is present in the premolar area bilaterally. In denture fabrication, both location, that is where the torus is present, and the size, how big it is very important. One more thing, the mucosa over the torus tends to be thin and will not tolerate the occlusal loading of the denture. It keeps on creating sores and pain in the area. Tori can be classified as class 1, absent, when no torus or very small size is present. That will not interfere with the denture construction. Class 2. Ridges have tori that offer mild difficulties for denture adaptation. A large midline window can be made in the torus region as advocated by Valentine. In mandibular denture, where the bilateral tori often cause difficulty in placing the lingual flanges and painful removal and insertion due to the undercut which is created by the tori. We can manage this by incorporating soft acrylic resin flanges and a resilient liner. This is called as the triple lamination technique. Two sheets of tin foil can also be used to give relief in the torus area. The postgraduate students can go through the article of Landa JPD 1951 to read more about the management of tori. Class 3. Tori are excessively large, prevent undercuts or extend to the posterior palatal seal in the maxilla. Surgical intervention is needed in this case. So if the torus is large or it prevents the seal of the denture, it should be surgically excised. We can see the first picture of palatal torus and mandibular lingual tori in the second one. This topic is very important as a frequent question asked by the examiners. Multiple choice questions are also framed based on the classification or its management. Apart from this, the pre-prosthetic surgery of torus is also asked. For example, the incision design is asked, that is the double Y. Erbium YAG laser is a new approach to excise or smooth these exostoses. Erbium doped yttrium aluminium garnet laser. Please read about erbium laser if you are preparing for NEET or your postgraduate exam. An essay type question on lasers can also be framed for the postgraduates. Interarch space or interridge distance. It is the vertical distance between the maxillary and the mandibular arches. As we can see in the image, the space helps in the teeth arrangement. It is recorded at clinical rest position in the upright position, but it can be accurately recorded on the articulated diagnostic cast, that is with the tentative jaw relations. If a postgraduate is selecting a case for exam, go for the tentative jaw relations to see the interridge relation and the interridge distance both. Normally 16 to 20 millimeter interarch distance is adequate to place the artificial teeth. Interarch space can be classified as class 1 enough, class 2 excessive and class 3 insufficient. In class 1, there is enough or sufficient space to accommodate the sum of vertical length of two opposing teeth and also the thickness of the denture base. Can you see the blue line? The mid one shows the class 1 interarch space. In class 2, there is excess interarch space marked as green in the picture. This is present in excessively resorbed ridge cases. In class 3, insufficient interarch space, which is marked with a red line in the image. This is mainly seen in recently edentulous cases where the ridges are very good with full contour. Large ridges are very good for retention, but teeth arrangement becomes very time consuming. The artificial teeth needs lot of grinding to be arranged in the limited interarch space. Ridge parallelism. It refers to the relative parallelism between the planes of the ridge. You know, when the teeth are gradually lost, the residual ridges diverge from each other. One very important term that needs focus is shunting effect. Often MCQs is framed from this. What is it? If the ridges are not parallel to the occlusal plane, what happens? When the occlusal forces are applied, the dentures tend to slide over the basilar tissues. The MCQ that is commonly asked is, shunting effect occurs in complete denture if the occlusal plane is lower in the molar area, if the occlusal plane is lower in the incisor area, occlusal plane is lower in the both, or due to poor muscular coordination. And answer to this is that if the occlusal plane is lower in the molar area, as you can see in the image on the lower right corner. And if it is so, there will be a tendency for the upper denture to be displaced posteriorly and the lower denture anteriorly. This is called as shunting effect. Now the next question is how this ridge parallelism is examined. Patient is brought to the clinical or physiologic rest position in upright manner. Lips are aparted and ridges are observed. It can be best observed on the articulated diagnostic cast with tentative jaw relations. Ridge parallelism can be classified as, in class 1, both the ridges are parallel to the occlusal plane as we can see in the first image. This is the ideal one. In class 2, either maxillary or mandibular ridge is divergent anteriorly as we can see in the second image. In this, only one denture will tend to slide forward. In class 3, both the ridges diverge anteriorly. Both the dentures tend to slide forward as we can see in the third image. Ridge relationship. Again, a very important point to be noted. It is the positional relationship of the mandibular ridge to the maxillary ridge. First step to record the ridge relation is vertical dimension at occlusion. Because the overclosure, that is the absence of the teeth, simulate a class 3 ridge relation when the patient is actually a class 1. This is called as pseudo or false or habitual class 3 ridge relation. Ridge relationship is observed at rest position in the upright manner. Lips are aparted and then it is noted. It is best seen on articulated diagnostic cast at vertical dimension at occlusion after recording the tentative jaw relations. Ridge relationship can be classified as class 1 normal, class 2 retrognathic and class 3 prognathic. In class 1 normal, as we see the first picture at the top, maxillary alveolar crest is directly above the mandibular ridge. This is the most favorable ridge relation and the ideal teeth arrangement can be done in this. In class 2, retrognathic, the second pictorial image where the maxillary alveolar crest is ahead of mandibular alveolar ridge. This can be due to the jaw size discrepancy also, presenting the mandibular ridge narrower and shorter than the maxillary ridge. The teeth arrangement should be considered here. For class 1 teeth arrangement, the overjet is 2 to 4 mm, overbite is 0.5 mm, while for the class 2 teeth arrangement, the overjet kept is 4 to 8 mm. Lower first premolar is skipped if there is less space in the lower arch. Can you see the third picture with class 2 mounting? This is how we check the mounting and the inter-ridge relationship. Now, here is class 3 prognathic, where the mandibular ridge is forward than the maxillary ridge, as we see in the first image, and the mounting in the second image. This again can be due to the jaw size discrepancy, with the mandibular ridge longer and wider than the maxillary ridge. I again repeat, pseudo or false class 3 should be ruled out due to overclosure. This is one of the multiple choice question also asked. Teeth arrangement is done edge to edge anteriorly and cross bite posteriorly depending on the ridge relation. Maxillary ridge and the palatal vault form. It is the ridge form and the palatal form through its cross section. It can be classified as class 1 square or gently rounded, class 2 V-shaped or tapering, and the class 3 flat. The picture here shows the class 1 type, that is the square or gently rounded, and it is the ideal form for both retention and stability. This picture, if you see carefully, shows the V-shaped or tapering form. In this, the retention is less as the peripheral seal is easily broken. This class is more prone to the lateral displacement and processing changes in dimensions. The polymerization shrinkage of acrylic resin, it leads to maximum gap in V-shaped palatal vault, the gap between the tissue and the denture due to the shrinkage. This is one of the MCQs which is asked. Now, how to manage to prevent the frequent loss of seal? The border thickness and the contour of the polished surfaces, they should be made over contoured, slightly over contoured during the wax up, so that the cheek and the buccinator muscle can perfect the border seal and aid in retention of the denture. Class 3 flat. Though this class provides sufficient retention and support, but the dentures may get dislodged by the lateral or the interiorly directed rotational forces, especially when the ridge height is less. So the stability is compromised in these cases. Balanced occlusion becomes very important to provide stability in these cases. Mandibular ridge form. The ridge form in cross section. It can be inverted U-shaped with good height, that is class 1, short inverted U-shaped with, that is class 2, and the class 3 unfavorable ridges. Class 1 is the ideal ridge with parallel walls, medium to tall with broad crest. We can see this in the first picture. Class 2 is also inverted U-shape with shorter height, as we see in the second picture. Here, compromised retention and stability will be there as compared to the class 1. Class 3 unfavorable ridge forms. First is inverted V. Though it may provide some stability and retention, but the thin mucosa at the crest of V-shaped ridge will always get irritated and soreness will be present. Second is inverted W. A concavity in the center poses the challenge for obtaining retention and seal, both. Ridge with unfavorable undercuts, as we see in the third image, in the upper row. It makes the removal and insertion of the denture difficult. Soreness in the undercut areas is common in these cases. Then in the lower row, the first image is of flat ridge, very compromised retention, stability and support. The clinical pictures also we can see the knife edge ridge form and the inverted W ridge form. Palatal throat form. The angular relationship of the soft palate with the hard palate is called as palatal throat form. The slope of the soft palate can be class 1 gradual, class 2 average and class 3 abrupt. In class 1, the soft palate makes less than or equal to 10-degree angle with the hard palate. So the slope of the soft palate is gradual. This gives good amount of immovable tissue at the junction area for good seal. The posterior extent of denture can be placed very easily. Do you know where the posterior extent of denture is located? It is 2 to 3 millimeter posterior to the posterior vibrating line. This is one of the often question which is asked. Class 2 palatal throat form is average. That is, the soft palate makes 45-degree angle with a hard palate. Tissue coverage which is available for the posterior palatal seal is less as compared to the class 1. In class 3, there is abrupt slope of soft palate as it makes 70-degree angle with the hard palate. Area available for the seal is very less and the distal extent of the denture also becomes very critical. Now it can be observed with T-burnisher intraorally, or we can also observe this on the diagnostic cast. There is another classification of soft palate by house. In this, the area available for the posterior palatal seal is considered. Class 1 is large and normal form. Class 2 medium size and normal form, and class 3 limited. In class 1, a imaginary line drawn across distal to the tuberosities. Then the immovable band of tissue which is present distal to it is measured. It is seen by the T-burnisher. In class 1, it is approximately 5 to 12 millimeter, as we can see in the picture. Class 2 medium, as we see in the first picture. Immovable band of tissue distal to the line passing through the tuberosities shown by the black dot. It is approximately 3 to 5 millimeter. In class 3, curtain of the soft tissue, it turns down abruptly. In this, the soft tissue starts 3 to 5 millimeter interior to the line as shown in the second figure. I hope this part is clear to you all. Now, palatal sensitivity, mainly asked and noted by the postgraduate students. It can be class 1, normal or minimal response, class 2, subnormal or hyposensitive, and class 3, supernormal, that is hypersensitive. The patients with class 3 palate respond violently to palpation. Patients overreact right from the impression making to the denture insertion. High gagging is present in these patients. They need to be identified, counseled and trained accordingly. So that's all for today. Thank you all. Please like and share the video. Subscribe for more and more learning. You can also mention your topics in the comment section or at drshwetaprostho@gmail.com.